Okay, well, hello everyone. We'll get started here. We do have another speaker coming, but we'll get started with the intros and hopefully she'll be able to join in a few minutes. So we hope that you enjoyed the breakout sessions and we want to thank you for all of your insightful questions and discussion. We will be using this link for the duration of the conference. We will now be hearing from Osha Keaton and Todd Goley, who will be presenting on the I-81 construction in a comparative framework. Osha Keaton was raised in Syracuse, New York, and is a proud member of the community. Ms. Keaton's passion for social justice and equality led her to pursue a Bachelor of Arts in Political Science from Clark Atlanta University and obtain her Master of Social Work degree with a concentration in community organization, policy, planning, and administration from Syracuse University. Ms. Keaton has over 14 years of experience working in direct service and community settings. She is currently an adjunct professor of social work at Syracuse University and teaches community organization and development. Ms. Keaton specializes in forming collaborative partnerships and guiding programmatic, organizational, and system change. Todd is the Community Engagement Director at Peace, Inc., the community action agency for Onondaga County. Formerly a SUNY Award-winning lecturer of history and humanities, Todd's current responsibilities include program agency development, constituent relations and engagement, internal and external communication, involvement with community initiatives and coalitions, and public-based research and planning for Peace Incorporated. Osha and Todd will introduce themselves and give us some background information. If and when you all have questions or comments, we invite you to use the hand raise function or the chat. A volunteer can then either unmute you or read your question off from the chat. Just a reminder, if you choose to have your camera on during this session, there's a chance you may be recorded. Osha and Todd, thank you so much for being here, and please take it away.
Morning, everyone. So my name is Todd Goley. Thank you, Nadia and Alan, for the introduction, and thank you for the opportunity that SUNY Upstate has given both Osha and I to talk a little bit about Syracuse and issues related to I-81. I'll introduce myself briefly first and have some opening remarks, and then Osha can jump in with her comments as well. Osha, do you have the PowerPoint presentation?
Yes, I do. Apologies, I'm having technical difficulties with my internet. So if I go out, just bear with me here. See, as I pull that up.
And as Osha's getting popping that up, I can talk briefly what Nadia explained. I am Community Engagement Director for Peace Inc. here in Syracuse. We are the community action agency for Onondaga County. There are approximately 1,000 community action agencies across the United States, essentially one county. As Nadia explained, I have been at Peace for 3 years, but prior to that, I taught modern European history, 20th century history at SUNY Geneseo, predominantly German and Eastern European history. But as you'll see very quickly, a lot of what I'd like to talk about today as it relates to Syracuse, talking about Syracuse and I-81, I think the underlining argument that I'd like to make, at least from a historical perspective, is that Syracuse and I-81, the issues surrounding it are not unique, that we see them across the country, but across the globe, and especially with individuals such as yourselves who are practicing medicine, potentially practicing medicine in other cities and communities, basically to provide some historical context that a lot of the issues that are here in Syracuse that we'll talk about are not unique to Syracuse and Central New York. So first, what I'd like to have you first understand is that I-81 essentially is a bridge, right? And an expressway. But to understand that I-81 is not unique, that cities for long periods of time have been impacted by the urban landscape, and that these urban landscapes oftentimes impact sort of class and racial perceptions and constructions, and that it's not unique to Syracuse and I-81. The first, and what I want to do is kind of throw out some snapshots today, and we can discuss more as we move into the discussion period. But really to provide you with some basic ideas to think almost globally and locally about Syracuse and I-81. The first is I'd like to start with a quote from Friedrich Engels, who in his Great Towns talked about the dehumanizing effects of space and infrastructure. And what's important with this is we're familiar with Engels and Marx with Communist Manifesto and Marxism, but Engels really was a true social scientist. And I think the picture here we have of I-81 in Syracuse is appropriate because already in the mid-19th century, he was outlining some of the primary conditions that he saw in Manchester, England, that we can apply to today. So he states that the upper class enjoy healthy country air and live in luxurious and comfortable dwellings, which are, I'm sorry, there's, I can't see. Osha, can you, there's this little box here, welcome, see live feedback as you rehearse. Can you drop that? Sorry.
Oh, I'm not sure where that button is coming from, but.
Okay. Oh.
Did it go away?
No, it didn't. I can't read the quote though, unfortunately. Sorry, all technical difficulties.
Let's see. Maybe if we pause for a second and I can send it to Nadia, and maybe that would help us.
Hi, this is Rachel. Are you sharing your entire screen right now? Because you can also stop sharing, and then when you go to share, select just your presentation.
Okay. Let's see.
And in the share, there should be a little drop down where or something will display all of your applications that are open, and that's where you should be able to select your PowerPoint.
Let's see. You said just do the screen.
You can choose to select just your PowerPoint presentation.
Okay.
Actually, Osha, I think I was able to get it on my end here.
Do you have it? Okay.
Can everyone see this?
Yes.
Okay, great. Thanks, everyone. So as I was saying with Engels, he states that the upper class enjoy healthy country air and live in luxurious and comfortable dwellings, which are linked to the center of Manchester by omnibuses which run every 15 to 30. To such an extent has the convenience of the rich been considered in the planning of Manchester that these plutocrats can travel from their houses to their places of business in the center of the town by the shortest routes, which run entirely through working class districts without even realizing how close they are to the misery and filth which lie on both sides of the road. For me, this is a particularly insightful quote. We oftentimes associate about, for instance, the divides between suburbs and city, and how expressways and interstates and the urban landscape help contribute to that. But also understand that that is something not unique to the last 50 years, that Engels identifies this. And he identifies how class division and othering stems from it, to the point that not only then are those conditions repressive, but that also the individual classes don't understand the conditions in which the othered live. Another example of this, if we want to fast forward, is our comments that are made by Frantz Fanon, who is the revolutionary psychoanalyst and revolutionary fighter during the Algerian War for independence against the French. And in his text on The Wretched of the Earth, 1961, he describes similar constructs of how the city is formed and how the city is constructed. And he talks about how not here just class, but also race is impacted by the urban landscape. For him, he says, the colonial world is a divided world, a compartmentalized world, a Manichaean world. The colonist sector is a sector built to last, all stone and steel. It's a sector of lights and paved roads. The colonized sector is a world with no space. People are piled on, one on top of the other, the shacks squeezed tightly together. Again, here what Fanon talks about is he focuses on broad boulevards in the colonist space, and of alleys and corruption in the non-colonist space, himself speaking as a Black colonized subject. Of course, his thoughts would later be incorporated in the 60s protest movements, for instance, Black Panthers and others, to understand how American cities also function according to race. All of this is to say that when we start talking about practices of urban renewal to take place in the mid-20th century, that many of you are familiar with Syracuse, with New York, I'll point out in a few minutes. Issues such as, for instance, Federal Highway Act that has built the majority of the interstates that we now enjoy. These are all, again, there are historical conditions and context for producing this. It wasn't just, for instance, the spread of the suburbs, but also for efficiency. Many of the individuals, and again, the idea of planning cities, of quote unquote progressive cities, of rebuilding cities and rebuilding locations that are blightful, right? These have origins far before even the 50s. One individual is the Swiss architect Le Corbusier and his concept of the radiant city. And this is one of his diagrams. Some of you might be familiar, for instance, with New York City and the Stoy City area, right? That was a Le Corbusier designed area. I.M. Pei, who designed Everson, if you want a more local example, studied and was influenced by Le Corbusier's design. Le Corbusier then built and believed then that space should be organized and most efficient. He also believed that for the health and well-being of people, that, for instance, gardens and living spaces needed to be separated from roads. But in the radiant city, he also outlines that those areas of a city, those areas of an urban landscape that are quote unquote inefficient should be reallocated for productive use. And again, understanding Le Corbusier is one of the most prominent urban thinkers that we see his sort of similar style of architecture with Everson, that again, it's this idea that cities are designed and planned in ways that are most effective. But what we want to ask is effective for who? Fanon and Engels before showed that, well, determining this is oftentimes influenced by class and race. Many of you then, of course, are familiar with New York City and probably familiar with Robert Moses, who this is a map, for instance, of the different, his impact on New York City and Long Island throughout his career in the mid-20th century. Again, unsurprisingly, Moses studied under Le Corbusier, and he very much was someone who you can see sought to redevelop locations that were deemed quote unquote full of blight. Oftentimes these blightful locations, again, were those who were outside of power according to class and race. Many of the expressways that you're familiar with, for instance, the Cross Bronx Expressway, dislodged many residents there. Many of you might be familiar with the sort of highly debated topic of the bridges out to Jones Beach. It's still contested that Moses developed those bridges with a limited height to prevent buses and trucks from accessing the beach, and the concept that most likely it would be the urban poor, Blacks and Hispanics who would be using public transportation to get out to the beaches. Again, understanding Moses, you're familiar with New York City and those expressways and those parkways. He as well was also contracted throughout the country. In New Orleans, one of the first urban renewal projects that was developed was by Moses, and he proposed to knock out, for instance, the French Quarter in the mid-40s to build an expressway that would make it easier for urban transit. What we have then is we fast forward to Syracuse and understand then when we talk about, for instance, the building of I-81, the confiscation of the 15th Ward, the relocation of those populations, Black, Hispanic, and Jewish populations, that again, these are trends that are going throughout the nation, and that these are trends that if after you leave Syracuse, you might see in your own cities. We'll very quickly go over this. We'll have more time to discuss this in the open conversation, but certainly when we talk about Syracuse, many of you are familiar with this concept of redlining, which were recommendations by the federal government beginning in 1937 about where investment and lending should take place. Red lines then, red districts were predominantly Black and Jewish. They were restricted in terms of loans and discouraged from loans. That red area in the middle, that is what was previously the 15th Ward, which was a predominantly Black district in Syracuse. Blacks migrated predominantly from the Great Migration in the 20s and 30s from the South. And increasingly then you see the rise of small businesses as well as homes within this district. As you're aware, with the building of I-81 in the 60s, this dislodged the neighborhood and dislodged the residents living there, approximately 90% of the African-American population. Again, when we talk about urban renewal, the idea that I-81 and this sort of infrastructure was appropriate because these areas were underused. Here is a picture of the 15th Ward. If you can see the map, for instance, right in the middle below the number of 15 is East Adams Street. And you'll see kind of like a square that goes down, a rectangle that goes down. That's the current SUNY Upstate. And one of the things we want to talk about, it's not just Upstate or Syracuse, but elsewhere, is our anchor institutes, which Osha will talk a little bit more about. Where did they get their building from, right? SUNY is supposed to be for public, right? A SUNY school, a public school, but public for whom? I think one of the interesting contradictions perhaps is that SUNY Upstate and the campus was built, much of the infrastructure that you see today was built on this previous 15th Ward that was confiscated and redeveloped. And again, these stories are numerous throughout the country. And so that's one of the things you want to think about in moving to your locations and practicing medicine elsewhere, is thinking about what is the urban landscape that you are working on, and what are some of those contradictions in terms of quote unquote development, and how it might impact those who are not necessarily enjoying or have access to power. With this, then I'll say one more thing and then hand it over to Osha. You know, one of the things then which I think we both really want to stress is that I-81, yes, I-81 is a huge issue that needs to be dealt with, but I-81 needs to be put in its proper context and in a larger sort of history, in a larger context of structural inequality, of how class and race has impacted urban planning, not just in Syracuse, but other cities. And what I'd like to end on is just a quick comment about zoning, and specifically what I mean by this. Long before I-81 was built, this is and redlining, the redlining map that I showed before. This is a map of Syracuse that was produced by the city engineer Henry Allen in 1919. This is just recently discovered in the National Archives a couple of years ago. What's really interesting about this is that he believed that the zoning of the city needed, and this sort of guidance needed to be produced quickly after race riots. You're familiar perhaps of 1921 Tulsa race massacre. In Syracuse, there were race riots in 1919 when white striking iron workers struck out against the Black population, some of whom were basically breaking strikes. From that unrest, Allen produced this map that offered guidance for how the city would later be zoned in 1922. And what's interesting is you have the birth of redlining here, but what's really interesting is how he labels this. Again, class, race, and space. How do we construct this? The green space, for instance, what is now modern day Strathmore, is a location for professional men. Those red locations, and the yellow, which is Jewish, the red location are manufacturing, and it's also deemed quote unquote Black, okay? And what's really interesting about this is that you see how the space and how the zoning of the city already in 1919 was being disguised and being interpreted according to class and race. That those areas, for instance, like Strathmore, single family homes, the idea of separating that residential from manufacturing, the idea of separating quote unquote white family stability with Black populations, understanding how that fits with those other ideas of Le Corbusier and some of those other plannings of urban renewal. We return to Fanon, and when he was practicing medicine in Algeria as a psychoanalyst, and my thought was saying, in treating a colonial subject through Western medicine, he asked the question, how is a structural analysis possible if we bracket out the geographical, historical, cultural, and social frameworks? I'll pass it over to Osha. Osha, I'll get your presentation up in just 1 second, okay?
Thanks, Todd. And while he is loading the second part of the presentation, I just take a minute to reiterate some of my, I guess, professional journey, how I came to be interested in this work as far as social work. So I am a licensed master social worker. And what that means as far as my practice is, although I don't do direct practice, I look at the community as my client. And as a result of that, I would be considered a macro social worker. And I assess the different areas and needs of the community in order to do community development, economic development. And so that is the approach that I take to my work, and center it, of course, in the voice of those most impacted in the community, as well as a social justice and racial equity lens. So.
Yep, just 1 second.
Okay. Thanks, Todd.
Yeah.
So the first slide you see here talks about the impact of urban renewal on the social determinants of health. I want to kind of personalize this conversation for you guys in the audience, because I know that you look at this work from a medical standpoint, but I do want to say that there is intersections in this discussion that we're talking about. The former U.S. Department of Transportation Secretary Anthony Fox stated that within the first 20 years of highway construction, which came under the urban renewal planning across the United States of America, in those first 20 years of doing that construction, over 1 million people were displaced across America. And those cities such as Miami, Cleveland, Nashville, and New Orleans experienced the same upheaval due to the demolition of their neighborhoods as Syracuse, New York. And this was all done to build highways. And much like in Syracuse, all of the construction was done in predominantly Black neighborhoods. And the destruction of these communities were justified by officials due to the belief that the neighborhoods were slum neighborhoods. And not only were the actions justified, it was backed by policies such as the ones that my colleague Todd discussed, urban renewal and redlining. The action of the government was a national trend that created lasting consequences in each of these neighborhoods. Neighborhoods, again, such as the old 15th Ward here in Syracuse, face a higher rate of poverty, a reduced life expectancy, and poorer health outcomes in their neighboring communities. And that's when you start to really see the intersectionality of urban renewal and the social determinants of health. Neighborhoods who had faced such upheaval almost 2 decades ago are still feeling the ramifications of lower educational outcomes, having issues around transportation, which not only serve as a barrier to employment, but also a barrier to nutrition. For instance, here in the city of Syracuse, over half of the census tracts are reported as having a food desert and or a food swamp, with many neighborhoods within the census tracts of 42, 43.01, 53, and 54 reporting not having access to any type of grocery store. And those census tracts that I just named, again, I say them again, 42, 4301, 53, and 54, all fall within the footprint of 81. Each of those neighborhoods have a median income of less than $34,000, thus making them qualify to be considered as below the federal poverty guidelines. And 40% or more of those residents in those census tracts make under $20,000. And we're talking about not single families, we're talking about families that have at least 4 or more. And the Onondaga County Health Department conducted a health assessment. And what they found was that a lot of the individuals and residents within that census tract falls within the zip code of 13207. And in that zip code, half of the residents have reported to not have health insurance. Next slide, please. So with all of these stark statistics, you may be thinking, okay, how can we help? How can we get involved to try to better the outcome for the residents in this city, as well as the residents of your home city, or wherever you choose to ultimately practice? This is where I believe the role of anchor institutions could really serve as a partner to help turn around some of the outcomes within communities that have faced upheaval due to urban renewal. Let's just define anchor institutions before we get too far into it. So anchor institutions are universities, hospitals, and other organizations that are geographically stationed within a community. They're not going to change your settings, and they can play a vital role in the local community and their economics. We saw that firsthand here within the city of Syracuse under the leadership of Nancy Cantor and Syracuse University. Nancy Cantor, next slide, please. Nancy Cantor, which you see here pictured in this slide, she believed in using and leveraging the resources of Syracuse University to create what she called social capital. One of her quotes is, "We must create social capital in our communities and social mobility for our current and future students." She looked at the residents of the city of Syracuse as a partner. And because of that, she was able to create initiatives that have had a positive lasting effect on the city of Syracuse. Initiatives such as the Near West Side Initiative and the Say Yes model. And even the initiative that I ran for 4 years, Greater Syracuse Hope, borrowed heavily from a lot of the models that she set forth as far as really going into neighborhoods, speaking to the residents, having them tell us what we believe what they believe the issues were, and being a thought partner with them and coming up with some sustainable solutions on how to improve the overall community. What we know about 81 and a lot of other of the highways and some of the communities that I named earlier is that, yes, it represents a physical divide, but it also represents a psychological divide as to how institutions at one point in the history of the United States interacted with the community. And if we are not thoughtful and intentional in our approach as far as interacting with the community in the future, that physical barrier could still serve to be a barrier that has, again, lasting consequences for not just the community, but also the institution. Because as Chancellor Nancy Cantor pointed out, the community consists of future students and future clients. So it should not be deemed a us versus them, but a we type of approach. So the duty of the anchor institution is to find ways to grow and partner with the natural resources of the area. And in this case, the natural resources are the community members. So a call to action and resources. I want to leave you with the call to action to really get to know the communities that you choose to practice in. Yes, we've talked about 81, and we tried to do it from a comparative analysis by doing the historical viewpoint as to how these same themes play out over the course of history, and then anchoring it as into some tangible experiences and examples as to how these consequences play out in everyday life. But there's still more that can be done. And when I think about some of the things that will come up for the residents that live in the shadow of 81 in the viaduct, as the officials call it, things like the environment. What type of environment are they going to be living in during the construction period? One of the things that I want to touch on, another health outcome for residents in those census tracts that I named, is that they have high rates of asthma. So just like She Matters used data to shape a program that has been extremely successful and impactful, maybe that's the next clinic that could be set up in the zone of impact, is an asthma clinic where the parents and children are taught about asthma and how air quality impacts how their health would manifest with having a condition such as asthma. Another thoughtful example that I could provide would be the lead exposure and what that will look like when they are doing construction and all of the dust that gets kicked up through that time. And another thing that should be considered when you're thinking about health outcomes for the residents in this impacted area, as well as them just going about living their everyday lives, is noise pollution. And what is that going to do to the eardrums of not just the parents, but also the children? And how would that impact their learning as far as having stress and not understanding, you know, them not being able to get a good night's sleep is what I meant to say. So these are some of the considerations that you can kind of look into and think, how can I use my education to create a program or outreach initiative to really help the individuals that may be impacted. But again, I can't say it enough, not just for the city of Syracuse, but also your hometown or wherever it is that you choose to go practice. Some of the resources that you could use to learn more about some of the things that Todd and I have discussed is community assessment. So Onondaga Health Department does a community assessment. The agency that Todd works for, Peace Incorporated, they do a community assessment here in Syracuse. And I believe Salvation Army does one as well as upstate. But to drive it back home to your local town or your local city, you can also find whatever action agency that's in your community that could tell you about what are some of the needs of your community, and start really thinking about designing programs and resources around those identified issues. So this is the end of our formal presentation, and I'd like to thank each and every one of you for coming out. And please don't hesitate if you have questions to drop them in the chat. Yeah.
Thank you so much, Osha and Todd. That was really wonderful, and I think a great overview of some of the issues that we're facing here in Syracuse today. I do have one follow-up question before we get to the questions in the chat. So I know we talked about referencing the community needs assessment when trying to decide what kind of advocacy or volunteer work to get involved with. But when we move to new cities, as we often do in healthcare, what are some ways to get started on these projects and making sure that we're not the only ones benefiting from them? For example, students building their CVs or different types of moves like that. How are some ways that we can stay integrated with these projects and not just kind of go on a tourism spree?
Well, the first thing that I would suggest is really creating, there's this metaphor about being at the table. So building off of that metaphor, instead of having a rectangular table, make sure the table is circular. And so what that means is really forming a true partnership with community members, taking the time to listen and understand what their needs are, and sitting back and letting them take the lead. So, I think about, again, referencing She Matters. I know the first program manager who built that program, but he was very intentional on uplifting the residents and the community members and really helping them find their confidence and their leadership capabilities, because he understood that once he transitioned and moved down to a different community, this was still an important need that needed to be met. And rightfully so, he's no longer in this community of Syracuse, but that legacy and that program is still here and still making an impact and a difference.
I would add to Osha's comments when looking for your opportunities, be thoughtful about them. Just as you apply for medical school, you do your research about the school, you do your research about the community, you speak with individuals. I'm assuming that most of you, when deciding coming to SUNY Upstate, it was a really holistically driven decision. And I would encourage you to apply that sort of rigor and that sort of holistic perspective in working with the community. How can that play out? As Osha said, PEACE is a community action agency. Our programs impact all aspects of the social determinants of health. Essentially, there's a community action agency in every county. There is a community action agency in every city across this country. Not only then are there opportunities to really combat the social determinants of health, perhaps through them, but even if you don't think it would be a good fit, every community action agency is required to do a community needs assessment, as Osha said, to maintain their funding. So not only does every community action agency provide social determinant of health services, they are driven by maximum feasibility, which means that their boards are not just members of the community and government, but also members who they serve are eligible to the services. But community action is required to produce data that outlines what are the conditions of the community. And so that could be something really helpful if someone's not even looking at an urban position. Maybe they're looking to practice medicine in a rural area. As Osha said, there are always community action agencies, and most health offices will produce those needs assessments. So that's the first thing. Look at your needs assessments. Encourage circular tables, as Osha said. Another thing is that, and OSHA's familiar with this too, many agencies and anchor institutes have long-standing partnerships, but those long-standing partnerships don't always adjust or always develop according to the needs. Sometimes, for instance, they were founded by students 5 years ago who've left. So the passions of that collaboration might be very different. So all of this is to say, do your research, be deliberate, be inclusive, and think critically about existing as well as potential opportunities.
That was wonderful. Thank you so much. We have about 12 minutes left for this session, so I think we can move on to some questions from the chat, and our volunteer Sydney can read those off. We're also happy to take questions via the hand raise function if you feel comfortable speaking.
So our first question is from Simone Seward, and she asks, what existing community plans or programs are currently in place to help address the challenges of the reconstruction of I-81?
Well, I would have to say from my understanding, I don't know of any formalized community plans to help address some of the issues of 81. But what I do know is that there has been a community movement to kind of halt some of the construction ideas around how 81 would be built. And you have community organizations like the Ty, help me out.
Urban Jobs Task Force.
Urban Jobs Task Force. I don't know why I was going to say Urban Justice Task Force, but the Urban Jobs Task Force, as well as I know the New York Civil Liberties Union have been working on the 81 project for a long time. It was actually spearheaded by Youssef Abdul Qadir, who is, much to our point, is no longer here, but the project has since been handed off to individuals who currently work for NYCLU. And so I know both of those agencies have worked very hard to try to center the voice of the community, but they talk about specific issues such as jobs and, again, things around environmental justice and environmental racism. I think what is missing from the conversation is a plan for relocation for those community members who don't want to be present during the construction period. And not just that, for a plan of relocation, but also a plan to bring those community members back, should they choose to want to come back after reconstruction has taken place. I'm going to now turn it over to Todd. Maybe he knows a little bit more about either one of those, but I do see a gap as far as relocation assistance and assistance to return to the impacted neighborhood.
I also have similar concerns with OSHA around those issues. In terms of organized, I think I don't really have much to add outside of OSHA, what OSHA suggested with NYCLU Urban Jobs Task Force. They have been arguably the most vocal and successful voices. One of the things I think NYCLU, for instance, is really put a focus on. Originally, there was intended to be a traffic circle around Martin Luther King Jr. School, which is on the other side of ESF, on the other side of 81. As OSHA pointed out, there was, in terms of asthma rates, I think asthma rates are a third higher in Martin Luther King Jr. School than in other schools. So you can see the impact of it right next to the building. I think that there are still, for me, and again, this is the historical perspective, and this is my historical orientation, is that planning oftentimes, in my opinion, happens out behind closed doors. And while I think that the sort of examples that I gave, it's very much a different time. I think that planners are being forced to be more transparent from community groups. I think there is a need for continued pressure among the community to raise their concerns about relocation, to raise concerns about what would the impact be during the construction period. And then also, we can talk about planned communities and we can talk about planned constructions. Things don't go according to plan. and we can see from historical examples, things are unaccounted for after the fact. So all the more reason to build and develop other sustained responses and what I would call civic responses beyond just Urban Jobs Task Force and NYCLU, because there will be need to have these continued dialogues, not just the construction, but also afterwards, to make sure that I-81 and the sort of projects that are being promised with it really deliver for the community. And to last point, again, I-81 is a symptom of a larger structural inequality issues here in the community. And so that's why those sort of civic engagements in those areas of exchange and dialogue have to continue on, because it's so much more, in my opinion, than just I-81.
Thank you. So our next question is from Titi Masvaur, and apologies if I didn't pronounce that correctly all the way. The question is, have either of you published papers on this that you can share? Or alternatively, do you have published papers that you can recommend that get at some of these macro structural urban development issues? And I will add that as everyone has been sharing resources and links in chats throughout the day, volunteers have been grabbing them so we can share them to folks via email after. So Todd and Osha, if you have things that you'd like to share afterwards, please feel free to do that as well, and we can distribute them.
So I can tackle this first, Osha. So Osha and I have been collaborating for nearly 2 years now. It's pretty amazing. So we started writing white papers. So these, and what we really wanted to do was create papers that were accessible to all. A lot of times, I think our frustration has been that people know that, for instance, redlining is a bad thing, but they're not necessarily aware of what it is and what its effects are. So we've collaborated on papers that are available on the PSync website, which is pretty accessible. We've written on redlining, urban renewal. We've written on zoning. We've also been fortunate to go on some public forums to discuss. So that's sort of our work. In terms of other sources, I would first, if you're interested more in redlining and its effects, University of Richmond has the Mapping Inequality Project, where they have uploaded every redline map of every city here in the United States, as well as descriptions of those locations. That's a really good, useful document. The Congress for New Urbanism is a national organization that has really tried to drive issues. For instance, they've written on Syracuse, Claiborne Expressway, Interloop here in Rochester, as well as discussing ways in which structural inequality can be overcome in those infrastructure projects. Another sort of tied to social determinants of health would be National CDC Places Project, which was previously the 500 Cities Project. Places now is much more expansive. They'll allow you to actually identify census tracts in terms of where there are higher rates of asthma, high blood pressure, et cetera.
Yeah. I think that was really extensive list of resources. And just to reiterate what Todd said, we would be happy to share our works with the audience, and we'll make sure to get that over to Sydney. And the CDC is always a great source of information, as well as the Bloomberg and Brookings Institute. They have a plethora of articles that deal with redlining, urban renewal, as well as anything looking at communities and how communities develop. Also, the Institute of Poverty Resource and Action Council, they have a lot of information as well, discussing community development. And the last resource I want to provide is the Annie Casey Foundation. They are traditionally a philanthropic agency. However, they publish a lot of reports about the work that they have done in the Baltimore area, especially around like health and health justice.
So we are at just about our time for this block. But if anyone has last comments, Osha or Todd, that you would like to share, and then otherwise we will be transitioning to our 10-minute break and staying on this link for the upcoming session.
No, I just want to again, thank you so much for the opportunity. Thank you for allowing me to kind of nerd out and speak about a topic that I love, and really just having this opportunity to interact. And good luck on all your professional endeavors, whatever field of medicine you're currently in or thinking about going to. Being that you're attending this conference, I know that you guys would be powerful practitioners. So,
yeah, I'm going to second Osha with nerding out. It's seldom that I get to channel my former historian, so I very much appreciate that opportunity. I appreciate the opportunity to speak with all of you. But I also believe that for us to progress and for us to really make change in the fields of medicine and health, we have to know our history and we have to be able to understand the mistakes of the past to improve our futures. So I appreciate this forum, and I appreciate the forum, your willingness to allow Osha and I share some topics with you today. Thanks.
Well, thank you both so much for the wonderful presentation, and to all the participants for the wonderful discussion. Like Sydney said, we are going to be moving back to the waiting room because we're going to load up the keynote speakers slides. So you all will be admitted back into the waiting room and then back into the link at 12:20 for the start of her presentation. So feel free to take a break if you need one. Thank you so much. Speaker, Dr. Heather Irabunda. Again, please type your questions in the chat, and our chat monitor, Sydney, will read them off during the last 15 minutes of this session. Dr. Heather is a board-certified OBGYN currently practicing at NYC Health and Hospitals, offering over 9 years of experience in the medical field. She received her Bachelor of Arts from the University of Pennsylvania in 2004, followed by attending a post-bac program at SUNY Buffalo School of Medicine and Biomedical Sciences, and earning her Doctorate of Medicine from Albert Einstein College of Medicine at Yeshiva University in 2011. She went on to serve as an active duty Army OBGYN as she completed her residency in obstetrics and gynecology at the National Capital Consortium Walter Reed National Military Medical Center, and joined the Guthrie Ambulatory Center as an attending physician in the Department of Obstetrics and Gynecology in Fort Drum, New York. She helped soldiers, spouses, and veterans by focusing on making sure military women had access to high-quality women's healthcare during their service. Dr. Irabunda, I will begin sharing your slides, and the floor is yours.
Cool. Hey, everyone. So, all right. So, welcome, everybody. I'm Heather Irabunda. As I've been mentioned, I'm an OBGYN who kind of had quite an interesting journey to this point in my career, but I'm based currently in New York City. I serve the community of the Bronx for all their general OBGYN needs, and I have some other things that I'm going to talk about. But basically, I consider myself your friendly neighborhood OBGYN that just so happened to find her voice in some way. And so I will be telling you a little bit about the things that I'm passionate about and how that relates to kind of public health and how we can improve outcomes for communities of color. So next slide. So in terms of financial disclosures, I do hold advisory board positions for both Johnson & Johnson and Moderna. They have not financed any part of this talk though. Next slide. Okay, so my ground rules are pretty simple. So I want this talk to be slightly different than most talks that you get at conferences. Especially from keynote speakers. I want this to be informal because I think that we should all be on somewhat of a level playing field, and that's how we learn the most and can move forward, hopefully, with some good bits of information. Additionally, I did say, listen with an open mind, and that seems pretty cliche, but I say that as in, we all come from backgrounds and experiences that affect our biases, and that affects how we listen and also how we act. And so I am asking everyone to think about what types of experiences they've had in their careers or lives to this point, and hopefully be able to see things from a different point of view. Additionally, in terms of questions, they're definitely key, and I will love to answer any and all questions at the end. Next slide. All right, so who am I? So I am Heather Bunda. I am first generation. My parents are both immigrants. They came from Nigeria and Jamaica. And I was born and raised in New York City. I grew up in the Bronx. I am from a working class neighborhood. Actually, my congressional district that I grew up in is represented by AOC, who often talks about the troubles that my community has in terms of access to care and social determinants of health, but we'll get to that. I'm also a product of many different types of schools. I started off in public school in the Bronx, overcrowded. We didn't even have enough desks in my elementary school classes for us to have our own textbooks. And that wasn't even in, the 70s or 60s or whenever. That is in the 90s. So this is an issue that's definitely recent and still ongoing in terms of education. But I highlight that to say that people can come from all different backgrounds, and that informs how they approach situations and problems and such. I also ended up getting selected to be in programs that allowed me to go to some fancy private schools. And then again, that all those experiences have also informed the way in which I approach the world. I'm also an Army veteran. I did my residency and my first few years out of training with the Army, both at Walter Reed and actually not too far from you guys up in Syracuse. I was in at Fort Drum, and I lived in Watertown. So I know Syracuse actually decently well. And apparently I'm a medical influencer, which is definitely a new term that most people, I guess I just kind of learned about it as I became one, but I have a social media platform. I'm on primarily Instagram and TikTok, and I also have a blog, which the reach is about, in terms of all followers, about 100,000. And through those means, I'm able to actually use my voice to affect change, which I think is shocking because I consider myself still your friendly neighborhood OBGYN. Next slide. So the reason why I went through my background is because lived experience is important. And I think that in times like these, where we're talking about data and we're talking about research, that's great, but lived experience is also important. And so that is a lot of the reason why there's so much advocacy in terms of making sure that there are people who are representative of many different groups within medicine and healthcare policy, because these people have different lived experiences which can inform policy changes. And it also frames what's important to us, and it frames what we ultimately end up advocating for. Next slide. So what does it mean to advocate for something? As we all know, the textbook definition of advocacy is the act or process of supporting a cause or proposal. And I think it's really interesting when we talk about advocacy in a healthcare environment, because a lot of times we think about it purely from the patient end. So patient advocates, right? So if you're in a hospital setting and something's going wrong, a patient's not happy, they call the patient advocate, and that person is the one who tries to bridge the gap and let the patient's grievances be known to hospital employees or leadership or whatnot. Additionally, we see advocacy in healthcare from patient groups. Like you may see people who are affected by different ailments like sickle cell or fibroids come up with advocacy groups, and they will go and lobby different sectors of the society to find funding or anything like that. But we don't really necessarily think of medical professionals in that advocacy space, because we're often told that advocacy work is somewhat political, and we should likely just keep our focus on the medicine. But I do think that there's a role for changing that kind of view, and I'll kind of get to that soon. Next slide. So I'm glad that I'm here at a health justice conference, because you guys are well aware of that medicine is not just disease states and treatments. And I, in my experience, not only personally, but professionally, came to see that very quickly in my life. I saw growing up people who didn't get care for things that if they had more money or different means or knew more about their options, they may have had different or better healthcare, and that would lead to better outcomes. Additionally, you guys, I'm sure, are all aware of social determinants of health, and I caught a bit of the last presentation where it seems like you guys were talking about some of those things, but as you know, environment, economics, education, community, access to health services, all of these things in a variety of different ways affect the healthcare outcomes of an individual person and groups of people. And so it's important that we remember that. And I don't know if people keep that as much in the forefront of their mind as probably a lot of you guys in this room, or those of us who, you know, are looking for it. Next slide. So what do I see daily as a doc from the Bronx? So I work at New York City Health and Hospitals, the largest public hospital system in the country, and I work in the Bronx. I work for North Central Bronx Hospital and Jacobi Medical Center. And so part of the community in which I serve lies within New York Congressional District 16, which is the poorest congressional district in the United States, not in the city, not in the state of New York, in the whole entire United States. And I see the effects of that. I see the food deserts where, you know, we're like, hey guys, you really should eat more fruits and vegetables and healthy foods, but like, where are people supposed to get that if they only have real access to bodegas and stores where the fresh fruits and vegetables are actually rotting, right? They have some of the most poor performing schools in the state of New York. And what was really interesting is that even as recently as last week, I was looking at some things for like a COVID tracking panel that I'm on in the city. And we were looking at specifically at school attendance in the city at public schools. And what was really interesting is to see the disparities and differences in attendance to schools since the rise of Omicron. We've actually seen there was a school within the area that I serve that had 0 students show up to school one day because all of them and or their families were sick with COVID. There were percentages like 11, 12% of school attendance, you know, throughout the last 2 weeks due to COVID in these schools, as opposed to other schools with different means and people who are able to isolate and, you know, have high quality masks. And like, for example, Park Slope, Brooklyn, where there were like 90-something% of kids going to school, their public school every day. So it's really interesting. Also, we have a higher Black maternal mortality rate than most places in the country. So in my little part of the Bronx, well, really a good chunk of the Bronx, Black women are 12 times more likely to die from a pregnancy-related death than their white counterparts, which is even higher than the overall Black maternal mortality rate, which is about 3 to 4 times. There's also a higher infant mortality rate. And as I mentioned, there's high rates of COVID-19 infection and death. And in terms of vaccine uptake, there's lower vaccine uptake in our communities. So this is the milieu that I'm working in, okay? So next slide. So given this experience and the experiences that I've had kind of going throughout my life, it made me think about what I could do about things, right? Because, and this actually started before the pandemic. So I grew up in, in this neighborhood. I actually went to med school in the neighborhood that I grew up in at Einstein, and was able to see things from a healthcare delivery lens and see some of the gaps and issues that in order to make the healthcare that this community get to be more equitable. And I actually then went on to Walter Reed, where I was taking care of kind of the upper echelon of the military. Then I was actually upstate where you guys in rural Northern New York, and got to see a different segment of the population, but that had similar issues. And then what it made me think was something is not working. We need to think outside of the box. And sometimes that means you need to listen to patients, listen to people around you, listen to your friends, listen to your family, because I don't come from a medical background in terms of my family. So they're quick to let me know what beef they have with the medical system and how they think it could be improved. So I took time to listen to people. And then, because I felt in a sense, there weren't enough people actually talking about these issues. And this is definitely pre-pandemic, but still, we're still seeing it now. And so I was well, we need a way for people to be able to hear this message in a way that will affect the way that they make policy, right? So I looked at what the most effective communicators of our time are using. So next slide. And so I looked to social media, because something that I found interesting was that when I would see my patients, and this was everywhere, this is when I was in Bethesda, Maryland, and the suburbs of DC. This was when I was in Northern New York. This was has been when I've been in New York City. I would have patients come to me and talk about some concerns they had with, let's say, their menstrual bleeding, their discharge, or their fertility. And then we talk, and then they would mention something they read online. And most of you guys are yeah, I get it. But it was even more than Google. It wasn't just a simple Google search or blogs or whatever. It was people are yeah, so I follow this girl on Instagram, I follow this girl on Twitter, whatever. And she's saying that her doc tried to give her this therapy and it really sucked. And don't even mention that to me. Or doc, have you heard of this therapy? Because this influencer said she used it and it's changed her life. And I'm the fact that this person on a social media app has enough reach and influence to cause me to have to address something that they have said online means that they clearly are effectively communicating whatever the issues may be. And so that's when I decided that I wanted to join it, because a lot of times, what we know social media to be is just fitness trends or makeup or even Twitch streaming, things like that. But the possibilities are infinite, right? So people think of kind of your medical blogging. Some people know Z-Dog and all those types of people. Those people start off on blogs, but even that is kind of dated, right? And so meet the people where they are. They're on Instagram, they're on TikTok, they're on Twitter, they're watching YouTube. These are the ways that we can connect with these audiences, not only patients, but also even people who are creating healthcare policy or have effects on healthcare policy are also taking in all of the social media. So that's why I started going that way. Additionally, traditional media, I think is also, there's a role for that, and I'll kind of get to that later. But again, social media is where I saw a big opening for possibility. Next slide. And so just like there are issues with diversity in medical spaces, for example, 5% of all docs in the United States are Black, 5% of docs in the United States refer to themselves as Latinx, there's a lack of diversity in social media and traditional media spaces that talk about medicine and medical policy. And so when I was thinking about doing these things back in like the fall, winter of 2019, I was like, I don't see anybody that looks like me on Instagram or whatever talking about these issues. And then you see a handful of these people on traditional media outlets like CNN and your local news. And with this lack of representation, we limit our conversations. And so because you don't have people who may have that at the forefront of their minds, we're missing conversations about equity and justice in a lot of these spaces. And so that's where I saw room for improvement. Next slide. And so I then also looked at like specifics of spaces because one of the big things that I've noticed in my time serving my community is that as much as we get the teaching about translating medical jargon into jargon that people can understand, regular speak or whatever, we still forget to do that. So oftentimes when people are talking to their patients in the office, explaining conditions, giving treatments, we're not translating it into a way that they can understand, both either in language we're using or the references we're making and things like that. And that also extends to our media. So I felt like there was a dichotomy there. There's the med Twitter, right? Where I have my thoughts and opinions about that I'll leave for another time. But I feel like it's a space that it's really like experts and physicians and other medical professionals are talking about industry things, right? They're talking, and it's very medical speak. And even if we're talking about issues with equity and stuff like that and justice, it's still at an industry level. And so it's not something that a lot of lay people can understand or relate to. And so, and people are watching, people outside of med Twitter, out of the medical community are watching these conversations. And they're cherry picking from it, as some people may notice with COVID-19 and vaccines and stuff like that, because medical Twitter is public, guys, in case you forgot that part. But it's very industry driven. And then there's the hashtag wellness spaces, right? So that's where I feel like more of your general public is talking about health. And this is where it's like, and it gets wild in the wellness space. We have, your Gwyneth Paltrow and your Goop, and you have, all kinds of wild stuff. And like, I'm a gynecologist, so I see a lot of interesting stuff in the wellness space, but also too, there's also conversations about how people are perceiving the traditional medical community and how we interact with them and what we say to them and what we do and how they perceive it and how willing or not or unwilling people are or communities are to take our advice. And I think it was kind of fortuitous that in a weird way that we had this global pandemic, because it actually highlighted the issues that were going on pre-pandemic with misinformation, vaccine hesitancy, because that's not a new thing, communities of color, having disparate outcomes in health access. These were all things that were being kind of toyed with on a smaller scale on social media, and it kind of blew up in the face of a global health emergency. So I think it was really interesting to see that. And what I've noticed, I mean, it's a little bit better now, but there still isn't that much overlap between kind of these industry spaces and the general public spaces. You can go to the next slide. And then I then looked at traditional media too, because I thought it was interesting to see how do medical contributors in media like affect the healthcare landscape, right? And prior to COVID, people were like talking about social determinants of health, but not like like not on CNN very routinely, not on, your local news, none of these things. And really medical contributors were usually brought on to do like kind of your feel good segment sometimes, right? So it's like, let's talk about like healthier habits for 2022. Let's talk about like hypertension or diabetes, because, we all know Aunt Sally has that. So like, let's talk about like ways you can encourage your family members or yourself to do better. Sometimes if there was like a major medical issue or new novel treatment for something that affected a lot of people, you may hear a little bit of buzz about that. Or if a celebrity had a baby and had complications, we were going to hear about that. They would bring on a medical contributor to talk about it. But, the whole gritty, like, why are there certain communities that have poor health outcomes than others wasn't really put to the forefront of things, especially pre-pandemic. It's a little bit better now, but not much. Next slide. And so basically, through all of this, right, when you start, I noticed when I started doing my health communication, which I started basically doing random like videos and posts about different things like your period, how to track ovulation, what a uterus is, basic things. Then you started realizing that people had so many issues with however they were getting their health care or access to the care and things like that. It then led into like the advocacy lens, because when you're able to communicate the importance of health or the importance of maintaining healthy habits, then it can cause people to improve their outcomes and spread that information. And in a sense, it's advocating for better health, right? And so it also lent like a place for me to be able to talk to communities, not only my own, but like even more communities about issues that they were having and bring a lens to it. And through that allowed other people to take notice of these things, like different politicians and things like that. So in a sense, by communicating these health issues and by having these open discussions, it really does lead to the ability of healthcare professionals to advocate for their patients better. Next slide. And so basically, at the beginning of 2020, so that's like actually 2 years ago this month, I created my blog and my social media platforms. And my express goal was to meet people where they are. I was not going to be talking a language they didn't understand. I expressly did not do anything on Twitter because I actually felt like it was more industry specific conversations, and that wasn't my audience. My audience was the general public. And then a big part of it too is that I wanted to engage with these people. I wanted to know about their desires, their fears, their experiences. And it allows you to take bold steps because then you're able to establish stories and, take people on a storytelling journey. Next slide. And the reason why it's so important, I felt like, to partner with the community, like my community, and partner with and engage in these conversations in a very public way is because, especially in our fields, we get very tied up in research and data, which is great, right? And so we're taught data drives progress, right? Where's the data to support this? Where's the research to support this? And that is true. And there's tons of research about health disparities based on, racial and ethnic backgrounds, on sexual orientation, all kinds of things, right? But we still find ourselves in the predicaments we are today. Specifically, something that I feel near and dear to is maternal health in general, but specifically the disparities in health, in maternal health that cause causes more Black maternal mortality. And things have gotten worse over the course of 20 to 30 years. Like the maternal mortality rate in America has steadily been rising. So as much as we have all of this research to drive this and to show us that this is the case, how is that affecting our policy to improve it? And so what I've noticed is that sometimes to get attention for these causes, lived experience and storytelling provides context for these things, right? So just by, us here spouting out, hey, so FYI, there was a study that came out that says that Black women are 3 to 4 times more likely to die in childbirth, or, whatever. Like, if you actually tell stories, that has been proven to catch people's hearts and minds a lot more. That's something in the military we were really big on, hearts and minds. That was actually the medical part of the mission. We were the hearts and minds portion. So I kind of delved back into that pocket. Next slide. And so in terms of Black maternal mortality in the US, right? This is my example of how hopefully this is still a work in progress, but hopefully this advocacy will lead to policy change, right? So the statistic, as I mentioned before, Black pregnant people are 3 to 4 times more likely to die in like pregnancy-related deaths than their white counterparts. I made TikTok videos, I made posts, I did this, I did that, whatever, right? One of the ones that really actually gained a lot of traction that I had gotten reached out to by a multitude of different actual politicians about was a video that I had made where I actually had pictures of 10 of the most recent Black moms that had died in childbirth, like the big stories, right? And so it led to, as I said, politicians reaching out, media outlets reaching out, and even industry people reaching out, like most notably Peloton reached out to me because they had a pregnant trainer, Robin Arzon, for those of you who are Peloton people, and she saw it and felt particularly drawn and wanted to know how can they help to do this, right? And this leads to people wanting to support initiatives to address disparities in the social determinants of health, right? One major thing that kind of bringing all of this stuff to the forefront through a lot of the advocacy that's done through media and social media has been the Omnibus Act that we're trying to get passed, which is a series of multiple bills that addresses multiple different social determinants of health and tries to create policy that will make things more equitable for communities of color. And so through literally TikTok videos, Instagram posts, and tweets, it has led to meetings with policymakers about addressing healthcare disparities. So it's not just all like a struggle twerking on TikTok. Some of it can actually lead to real policy change. Next slide. And then one of the biggest things that I think we need to acknowledge is that through social media and through these novel ways of reaching people, we are democratizing thought leadership in healthcare spaces, because oftentimes someone who looked like me, who has tattoos, a nose ring, is in a larger body, would not be considered, and does not hold, an academic title, would not be someone who these politicians or people would reach out to. And so you're getting a certain type of person, right? Additionally, you get community activists, Gen Z, everybody talks about Gen Z. They have voices and they use them on TikTok a lot in different marginalized communities. And so it really democratizes how people think and what they do and what perspectives we should be listening to, because you no longer have to go through very traditional means of, okay, like I did a fellowship or an internship at ABC or something like that, and then as a resident, and so that led me to become a medical correspondent, and now these are the things that I do. You know, it's now like you can sit in your home like I'm doing right now and just talk about the issues you're seeing and provide some context to all of the research we're all reading and listening and taking in. So I think that's what's really novel and amazing about using social media in, like, especially healthcare and public health spaces. Next slide. And so, welcome to the future of medicine, as I like to say. These are some of my favorite people. And I always say the future is female, so everyone here is female. But we have, and most of them are OBGYNs because I'm an OBGYN. That's me with my patented name chain, because you can take the girl out the Bronx, but you really can't take the Bronx out the girl. Uche Blackstock, who I don't know how many of you know who she is, but she is brilliant and fantastic. A friend of mine who does a lot of work in the health equity space and uses her, and she's a MSNBC medical contributor. Dr. Jennifer Lincoln, she is an OBGYN who is like super popping on TikTok. She has, I think, like 1 or 2 million followers. And she does a lot of debunking, demystifying stuff, but she also talks about social issues in terms of misogyny and how we perceive the female body. And so it's really cool. And then we have Allie, who is also, she just finished her residency. So she's now an attending physician. She's also an OBGYN. She's Puerto Rican. And she talks about her experience in being a Latina in the field of medicine. So this is the future. This is what it looks like, and we are democratizing it. And by having people with different experiences and different perspectives, we are representing different parts of our communities, and we are giving them a voice, and we're allowing them to advocate for the things that are important to them. So with that, do you guys have any questions? Next slide.
We have a hand. Oh, sorry, go ahead.
Oh, sorry, my name is Nicole. I'm one of the attending a child neurologist here at Upstate. Oh, I can be visible now. Yay. So hi there. Thank you so much for coming to speak. It was awesome to hear you. I'm from Montefiore. I trained there for my residency.
Oh, very cool.
Yeah, so I was very excited to see you on here. So I was wondering, what has it been like for you to have this social media presence? I can only imagine, what it's like. Does it ever come with certain, like vulnerabilities, like, and challenges? If you're talking about that, I would,
Oh yeah. So, I mean, because I do talk a lot about some of the more controversial things in medicine. I mean, apparently COVID-19 and the vaccine is very controversial, which is interesting. Like, just even providing information on that and talking about, healthcare disparities, and then also talking about challenges with things like fat phobia and whatnot in healthcare. You get death threats, which is like really strange. Yeah, you get death threats, you get people, I personally, thankfully, have not had this happen to me yet, but like people will dox you, which means they'll like put all your personal information, like where you live, like your family's information out there. You get trolls, you get like, some of it can be really rough in terms of kind of abuse standpoint of things. But in terms of the really positive things, I've definitely had patients come to see me because of social media, and like not even just like in the whole like weird, not necessarily weird, but fangirl type of way. It was more so like, I have had some really difficult experiences or issues or interactions with healthcare providers in the past. And so I specifically sought you out because I felt like I relate to you and that would be good. And so I feel like there's been a lot of really positive things with that. Also too, it's just really funny because as much as people are moving to the future a little bit with acknowledging that social media is powerful and that people and that we need to engage with it, it's still, you know, you still get kind of like the sly comments from like your colleagues, like, oh, like you're, you know, like a social media doc, which is also really entertaining, but it is what it is.
Thank you so much for answering my question.
Yeah, no problem.
Hi, Dr. Heather. As a co-host, I'm unable to raise my hand. I just really quickly wanted to, as an 8-year veteran, I just wanted to say thank you for what you did in the disparity, even in the military that you saw. That was one big reason I didn't stay longer than 8 years. And as a lower enlisted person with only a couple years in service, I actually had to go and fight using Army regulations to be able to see a gynecologist for my female problems instead of just a field medic who could stop the bleeding, which in my case wasn't needed. So I'm really glad you talked about that and you've advocated and helped women there. And then also, I think I just wanted to say, because I was speaking with a nurse practitioner student recently, and I come from a background people wouldn't normally imagine and are still afraid of seeking healthcare. They're still afraid of talking to physicians. They're still afraid of questioning what they feel they're told and feeling that they don't have any choice in helping with their healthcare. And then also, as far as advocating for disabled and low income family members. And so I just want to say as a tech person that's where at Upstate why I'm here and not making 6 figures someplace else, is that for me, even personally, finding that blend of being able to help people and help access using technical skills has been really important to me. And I'm always so happy to run these every year because I learned so much, and I'm going to check out all your information you put out there. To the people that are co-chairing this, thanks for letting me talk. I just was really passionate. Dr. Heather, you're amazing. Thank you.
Well, thank you. And I totally understand in terms of like, and I talk actually very extensively about being a person seeking like GYN care in the military, because it's really, really rough in terms of like, there's a lot of sexism and it's bad. So I'm glad that you kind of, you know, handled that situation. But yeah, it's really interesting to come at these problems with a different perspective, or one that people don't listen to very often. I wouldn't say it's necessarily that different. I think it's just a perspective that they're not constantly like, it's not constantly thrown at them, where it's like, no, like, we have to talk about this. There's no way that we're going to improve outcomes out here if we don't talk about social determinants of health. Like, my patients can't get to doctors, my patients can't get their medications, my patients can't eat the foods you want them to do, they can't social distance, they can't isolate. So like, we actually have to be practical with this stuff. So I think that the more voices that are out there that are changing that landscape, the better, because as most people know, like, you know, you have the policymakers up on top, even healthcare policy, and then we're the people who like have to execute, right? And sometimes it's not the same, it doesn't work.
And on the topic of food deserts, I just want to mention this one also because I think that's a really important topic. Dr. Joseph Nema, I believe he's in pediatrics with Upstate. There's a ton of Upstate people on here. He runs some great programs with trying to reach the community, trying to get access to healthier foods and make that. So if anyone is working in that field or doesn't know Dr. Nema, is really passionate about that, reach out to him because he does a lot of work with trying to, I think there's a farm even in downtown Syracuse someplace, a lot of great things. I just had to throw that out there too, because he's doing amazing things and I don't hear it talked about or really even publicized.
Hi, Dr. Heather.
Hey.
Hi, my name is Nakia Chambers. I serve at Upstate as the Director of Multicultural Affairs, and I thank you for joining us today. I also engage a lot with our diversity access through employment and also with our admissions process. And I'm finding that there is a growth in social media presence, even with our applicants. And that's something that is not necessarily normalized when you are coming through your access point. So and I know a lot of our current students and a lot of our applicants are showing and listing their social media handles in their application and speaking about them in interviews. How would you, in this field start to begin the conversation of normalizing social media presence to begin conversations and creating spaces? And what advice would you give for, our current students that may have, social media spaces and how to navigate that in order for that not to negatively impact them?
Yeah, so it's really interesting that you bring this up because it's definitely very like novel throughout, like, everywhere, right? What's really interesting is that I have, through doing this stuff, I've now developed a lot of friendships with people who have like these new titles and departments. Like, for example, Austin Chang, who is, I don't know if he's still the president of like, there's like a social media like association for healthcare workers or healthcare people. And he's the president of that, but he's also the chief like social media officer for Jefferson Medical School, which I think is like really entertaining, like in a very cheeky way, but like also very important because like he really truly has opened up discussions and conversations, not only within Jefferson, but in academic circles about normalizing social media and social media presence, because it's not only that individual people like, people like me or students or nurses or whomever are developing social media presences on their own. Now there are actual entities like different hospital systems, things like that, that are trying to improve their reach on social media because everyone sees it as an opportunity to improve that. What I always recommend, and there's a lot of preliminary conversations happening in most schools, in most healthcare systems, is how you want that to look for your organization, right? And how you want to utilize the people within your system who may already be engaged in this stuff to, see if you can work with them or how that works. But in terms of, and so there, I feel like we just need more open dialogue and to figure out like what the end goal of this is, like for a hospital system or whatever. Like, do you want to just talk about what services you provide? Do you want to provide patient education? Do you want to do all of that stuff? Like, trying to really establish what you want to do with it, because the possibilities are endless. In terms of people like students who are either applying or are currently students in med school or, going to residency, things like that. In terms of navigating social media or like, or the negativity or whatever that can happen through that, I always just say, like with anything, just be careful what you post, right? Like make sure that's something you are going to stand behind and you're not going to be afraid to talk about it in any context, because it's shocking what context these can come up. And like, for example, I post random things on my social media all the time and you don't even realize who's following you, right? Like the CMO of your hospital could be following you on Instagram or whatever. You don't necessarily know that. And they will know that like, instead of you being at work that day, you were out getting your nails done or whatever, if that's the type of social media presence you have. And so, or like if you have a particular political belief or affiliation or whatever, you have to stand behind that, right? And so if it's not something that you would be willing to talk about in a professional setting, like because it will come up in a professional setting, then you may not want to put that on your social media. that is the biggest piece of advice I can give people. But I do think it's a powerful tool. It's something that people can use to share their interests and to show their creativity and help people.
Thank you. Thank you for that.
So we have a question in the chat, which is, Dr. Heather, can you share your perspective on partnering with midwives and community-based doulas to help improve care for Black pregnant people?
So I strongly believe in the need to have partnerships with all of these people. And I felt that before I was on social media, but like even more so now. Because guess what, guys? They are, your patients are going to them. Like no matter how much you want to say or you want to discourage or whatever, they are going to these people, right? So we should be focusing on safe outcomes and like, I think more so coming together. And so what's been really interesting about things is that I have taken the opportunity to talk to a lot of, especially doulas, midwives too, but a lot of doulas, because there's, you know, they tend to be people on social media that have very strong opinions about like the medical industrial complex and obstetricians and gynecologists, and we're all evil and we're all bad and we're all trying to do C-sections on people and it's terrible and like you should have your baby at home, right? But it's like, it's been a very interesting conversation that I've had with many of them, even some of the pretty radical ones, because guess what? They never actually sat down and had a conversation outside of an exam room or a clinical setting with an OBGYN. Like they've never done it, right? These are all thoughts and opinions that they have developed in clinical settings, right? And so something that I have felt really strongly about that I think that social media has helped out is to take these conversations outside of those spaces, and then they can actually see you as a person, and they can actually see that like, oh, not every OBGYN is this money hungry person who's trying to do a C-section before 5 o'clock, you know what I mean? Or yeah, you know, there are many of us who, you know, want to reduce the C-section rate in the country, or yes, you know, there is a role for out of hospital births, or there is a role for this and there is a role for that, or there's ways to do things safely. Like, that's what I think the power of using these non-clinical spaces like social media does, is that you can actually have the conversations that you need to have and like take down the temperature a notch, because I feel like oftentimes it's like, you know, like you scroll through social media and like, there'll be, you know, people who are like, no one should have a baby in a hospital. Like all doctors are bad. All, you know, hospital midwives are bad. Everything is bad, right? And then like you start talking to them and you're like, well, what about this case? Or what about that case? Or like, just tell me why you're so upset. Like, that's where I start. I'm like, tell me the reason why you have this feeling, and you know, and validate some of it, because some of it is true. And like truly having a conversation with people improves that. So I think there are bridges to be made, and I am definitely for building those bridges. I've actually also have a podcast that I've had the president of the National Black Doula Association on there. It's pretty hardcore. She is a tough interview to do, but like we actually have a lot of mutual respect and love for each other that has developed over time, because we have been on panels together and have had to have difficult conversations together. Additionally, I like talked to a midwife who owns a birth center, because I'm like, what is that experience even like, right? Because what we have to understand is that even from our end of things, we make judgments on experiences. And so in medicine, we make, you know, judgments on what doulas are like, what home births are like, whatever is like, and then they make the same assumptions. So when you peel the layers back and actually have to sit in front of each other and validate and talk about why you feel a certain way, it disarms people. And so I think that I've developed way more of an appreciation for a lot of these things. I've changed a lot of the ways I speak about certain practices and things, because you learn a little bit. And yes, I'm not gonna, you know, support things that I don't think is evidence-based or awful, but like, you know, at least I can have the conversation with you and we both can leave it not feeling like we've disrespected each other. So there is a role for, you know, communities-based doulas and out of hospital births, but, and midwives. And I think that, you know, we need to respect those things. But I think my time on social media has really helped me establish those relationships and understand that things are okay.
Thank you. Okay, and then we have another question asking, how do we emphasize triaging what social media platforms to use for valid information, especially as a person not in medicine?
So it's actually something that I put as a disclaimer on, like, when there are different types of ways you can post on. I primarily do most of my things on Instagram, right? And I do some informational posts where it's just like kind of like a slideshow, right? Where a lot of times it'll be updates on COVID vaccines or updates on Omicron, updates on this, whatever. And one of the slides, usually either at the beginning or the end, always says that even fact check me as well. You know what I mean? Fact check everyone. Like, just because I have MD at the end of my name does not mean that you should automatically trust what I say. We've seen this. Joe Rogan Experience recently proved that point, as well as many other people we see on TV and social media. And so I am always saying, like, know who's giving you your information. A quick Google search will tell you if somebody has credentials. You know, I always say, because one of the sad parts about social media is that aesthetics work really well. And so things can look really official, like all those people who are like selling ivermectin or whatever and selling televisits. I actually went on their site because I was curious, and I'm like, it was really hard for me as a physician to find out where the medical basis of this is from, because it was a beautiful website, looked very official. And it's like, until I went to the people who they were citing, and none of them were immunologists or virologists or infectious disease docs or anything related to that. That's when I was like, oh, so, and I'm a doctor. So I'm usually like, hey, like, fact check, find out who's giving you this information, right? Is this person like even in medicine? Is this person in the field of study that they're speaking on, right? So like, is it a radiologist talking about ivermectin? That doesn't work, right? Or like, and then if they cite a study, like, is it, you know, like, you can quickly see if it's on PubMed or not. You know, I usually tell them ways to fact check as opposed to like actual platforms to use versus others, because they're going to go on everything and they're going to hear things from everywhere, and it's all going to, like, you know, make it into their head. It's more about teaching people how to think critically about what they're consuming. So I tell them, fact check everything. Even if somebody is a physician, fact check it. Like, there's ways to do it. Like, if you do a search and you notice that a whole bunch of other physicians or medical professionals are saying similar things, that's probably right. You know, like, if it's like this person's a lone wolf, you should be concerned. And you can always take it to your own physician if they have time to address it.
Well, thank you so much. That puts us right at about 1:20. So I want to be respectful of your time. That was an amazing presentation. I think we all learned a lot. And as we said, this is 2022. So this is definitely how we're going to be practicing medicine for the coming years. So thank you so much again. Does anybody have any final comments or questions?
Well, I want to thank you guys for having me. This was awesome. Not gonna lie, I'm kind of excited that this became virtual and I didn't have to come up to cold Syracuse, because I do remember how cold it gets up there. But yeah, it was really lovely to talk to all of you guys. And I hope that you guys will also use your voices, maybe on social media. Maybe we'll, like, you know, chat at some point. And, you know, you can advocate for the things you find important as well.
Thank you so much. Well, so this was a great day. Thank you for all of the engaging and thought-provoking questions and comments throughout the day. I would also like to express my gratitude for each of our speakers who helped to make this conference possible, and last year's chairs, Samantha Williams, Isabel Thenor-Lewis, and Angelina Ellis, who created an incredible framework for hosting the conference virtually, and we hope we did it justice here today. With that being said, this conference would not be possible without Rachel Espinosa Kim, who was instrumental in facilitating the technology and logistics for today. Lastly, thank you to everyone for your attendance and participation. We are so happy to have representation by students and faculty from all of the upstate colleges here today. In 2 short years, my peers here will be my colleagues, and I'm so happy to know that I'm among a group that is committed to educating themselves and making strides towards health equity. On that same note, thank you to all the faculty who are here today. Today, I'm very proud to be an upstate student, and I hope we can use what we have learned here today to take actionable change.
Hi, everyone. Just to add to that, it's been a pleasure to be here at the concluding session for the 2022 Health Justice Conference. The main purpose of our meeting was to emphasize the personal and professional roles of healthcare providers as leaders, educators, and social advocates. I sincerely hope you enjoyed our plenary and breakout sessions today and glean takeaways for greater advocacy opportunities in your practices and communities. I would also like to take this opportunity to thank our esteemed keynote, captivating speakers, and outstanding panelists, our partners at AMBOSS, the SUNY Innovations and Partnerships team, Museum of Science and Technology, and throughout the local community. In addition to that, our faculty and staff at our home institution of SUNY Upstate, as well as the members of the Health Justice team, our brilliant co-chair Nadia, the attentive volunteers without whom none of this would be possible. And to summarize, I hope as we reconvene for health justice conferences in the years to come, we can be proud of our work here today and the work that we shall accomplish going forward. We should judge ourselves not on just our professional accomplishments alone, but in conjunction with how we have addressed the world's inequities. Thank you all for your time.
One final note is that based on your attendance here today, we will be sending out a post-conference survey. So this survey helps us to make guided adjustments to the conference year by year and also to improve accessibility options. If you would like, at the end of the survey, you can include your email, which will enter you into a raffle to win either AMBOSS exam prep codes or tickets to the Museum of Science and Technology in Syracuse. And those should be coming out within the coming days. So thank you again, everyone, for a wonderful conference. We hope you learned something. And if you did, please feel free to share with us on our social media accounts.